moderator. Good evening, this is Brian Davis. I'm from Texas Tech El Paso, and I'm very proud to bring a distinguished group of speakers for the Resident and Fellow Training Webinar Series for the Society of American Gastrointestinal Endoscopic Surgeons, Video Editing and Preparation for Innovation in Competency-Based Education. I'm going to talk a little bit about our speakers for a moment. They'll give about a 20-minute presentation followed by a 20-minute group discussion, and then we'll go into some details about SAGES. We're very proud to start with Gerald, who is a professor at McGill University. He's also the Associate Dean for Education, Technology Innovation, and Director of the Steinberg Center for Innovation and Interactive Learning, who's received the SAGES Distinguished Service Award and Pioneer in Endoscopy, followed by Caprice Greenberg from Medical University in Augusta, Georgia, who's the chair in the Moritz Monsberger Distinguished Chair in Surgery, and also founder of Academy for Surgical Coaching, which is playing an increasing role in SAGES. Our next speaker after that will be discussing video editing for presentation for innovation at national meetings with Dana Telem, who's the chair of the College of Surgeons Video Education Committee. She's also the associate chair for quality and patient safety at University of Michigan. And last but not least, we have Jaisa Olasky, who's going to speak about video-based assessment for competency, which is the next big great initiative between SAGES and the American Board of Surgery. Coming from Boston with Beth Israel Leahy Health, who's also the Board of Governors for SAGES. I want to welcome everybody. And if we can please start the slides for the SAGES presentation. Talk a little bit about SAGES. We're very proud to have over 430 participants that are mostly residents and fellows, but also from across the world. And we have a great diversity of members. Let's go to the next slide, please. Benefits of SAGES membership include substantial registration discount in the annual meeting, professional development resources, the meeting with webinar and other courses, access to a network of over 7,000 colleagues and experts, online subscription to surgical endoscopy, and members-only research grants and career development awards with numerous opportunities for involvement in leadership with task force and committees and peer reviews, including a great surgical family. SAGES mission goals are reimagining surgical care for a healthier world. Mission being to innovate, educate, collaborate to improve patient care with values of inclusivity, innovation, service, excellence, and a global community with an emphasis on fun. So I'd like to encourage residents and fellows to please sign up for the candidate level in membership. And then we also have a candidate for medical students and want active participation, increased growth in the organization. We do have a chat box, which I'll be monitoring for the discussion at the end. And then we will have a group discussion at the end and a survey. So please hang in for that survey at the end. Thanks so much for everybody for attending. I'd like to start with Dr. Freed. Thank you so much for speaking.
Okay, hi, Brian. Hi, everybody. I hope you can see my screen and you can hear me clearly. I just want to start by pointing out the background behind me, not on my slides, but me. This is Montreal. Sunny, beautiful day in June, and SAGES will be meeting in Montreal at the end of March next year, and I hope you all will come. I promise you a great time. There's lots to see. There's lots culturally to do, and the principles of fun that Brian mentioned will be certainly part of what we do. So I've been asked to talk today about the future of video storage and artificial intelligence to judge competency. I do have a disclosure that is relevant to the talk, and I work as a consultant for a company called Theater, which is in this space. Now, I was asked to talk about three things, and I'll kind of break them down. The first is storage. The second is the application of artificial intelligence or computer vision to videos taken in the operating room. And the third is putting this together to judge competency. I'd like to start by the premise that I hope all of you will agree with, that surgery is an elite performance field. Much like elite sports, music, dance, chess grandmasters, etc. And if you want to learn something from those fields, the use of video, particularly in performance like sports, dance, and some fields of music, it is really, really critical. And the concepts of how videos can help in these elite performance fields is in preparation for performance. So review videos, really highlight some things that you want to accomplish. Then you perform, you video your performance, and then you review that and you debrief. And in so doing, you identify areas that you want to improve upon. The fact that this hasn't been an intrinsic part of surgical training is a bit surprising. And if you speak to people in other elite performance fields, they will really be surprised at how little we use videos in a formal educational way. And there is always an opportunity after we do an operation, no matter whether it went smoothly or less than ideally, to ask ourselves what went well, what could we have done better, what are the lessons we could learn from this case and reviewing this video, to take forward both in terms of practice, planning, as well as changing our behavior in the operating room. But ultimately, we want to use videos in a positive way and end by reinforcing what we did well. Again, I think all of you would agree with me that what we do in the operating room matters. There's no substitute for doing an operation well. And you could take the lowest risk, young, healthy, slim person, and if you do an anastomosis poorly, that outcome is going to be a bad outcome. And when we look at ways in which we manage outcome science now, we look at patient factors, we look at processes of care, but we have very little grip on what we do in the operating room. And that includes both the technical aspects, how well we cut and sew and dissect, as well as the judgments we make in the course of an operation. So if you believe in that premise, then we have to adopt our surgical education programs to teach and evaluate what we do better and more efficiently. And we have to identify what we do in the operating room that really makes a difference and what we do that is perhaps a stylistic difference between surgeons. In order to get there, we need to document exactly what is done in the operating room. The way we do that currently is the dictated operative report. But I'll get to this in a few minutes. The dictated operative report, as you all know, is a somewhat inaccurate and perhaps idealized version of what went on in the operating room. So we really need to understand, document it, and then ultimately relate what we do in the operating room with outcomes that occur after surgery. And by so doing that, we could truly understand what are the really critical areas that we need to focus on, both in terms of education and evaluation. So how do we do this currently? And I know that every institution is somewhat different. My experience is that whether a case is videoed or not is somewhat random. It's not done routinely. It may depend on whether you expect a case to be an interesting case, an educational case, or whether the surgeon's habit is to record videos, or whether the resident or fellow pushes you to record the videos. And interestingly, there are many cases where we wanted to record the video and we forget to start the video, or we paused it, we forgot to resume it. So the actual act of recording videos needs to be done somewhat better. Then once the videos are recorded, they are often stored in many places, sometimes with poor security. And again, this may vary from institution to institution. But people walk around with videos on USB keys, portable hard drives, DVDs, on servers, etc. If you really want to find a video, it's really often very difficult to find a specific recording when you want it. And if you want to search for videos based on specific criteria, unless you're a very well-organized department with a librarian or something, the ability to search for videos based on specific criteria is elusive. Once you get that video and you want to record a video, review the video, it's often pretty tedious. You don't want to go through 2 or 3 or 4 hour video to find perhaps a 15-minute segment of the operation that you want to focus on for the purposes of education or evaluation. So navigating through the videos, often you do it at high speed, you fast forward it, you back it up. It's pretty painful. The other problem is that if we want to improve our performance and relate what we do in the operating room to the medical record, what we do in the operating room is not in a database format. What we do in the operating room currently is based on the operative report, which is in natural language. And unless your institution has got very sophisticated natural language processing capabilities that can extract information and then put it in a database that's searchable and then relate it to outcomes, we are lacking that. And unless we understand the impact of what we do in the operating room on outcomes and safety, we are still back in the ages of, I like to do it this way. So if you agree with me, and it might be informative for you to review a number of operative reports, and I think you will find that there are errors of omission, that there are things that occurred during the operation that were not reported. There's a lack of use of uniform terms to ensure that all the key elements of the operation are described in language that is uniform. Therefore, it's difficult to search. And of course, sometimes the operative report is somewhat delayed and there is a recall bias. And sometimes the surgeon wants to put the best face on the operation that she or he did, and there may be some bias in that regard as well. I'm sure that all of you have been in situations where you've had to take back a patient who's been operated on by someone else. And wouldn't it really be ideal to know what was done at the previous operation, to be able to navigate rapidly to that part of the operation that might relate to the problem the patient is manifesting and help you decide whether perhaps you're a little concerned about that anastomosis and you feel the patient should go back, or it wasn't quite as dry as the operative report said it was. So having access to video documentation of surgery is really helpful in safe patient care. And honestly, it's pretty opaque to those who are not present based on what we currently have in the operative report. So I think the importance of video documentation of surgery is really something that should occur in every operation. And if we could then extract data from that using technologies such as artificial intelligence, then ultimately we're going to be able to use the information we glean from the surgical procedure and help us make real-time operative decisions based on data. So first steps, if we want to get there, is to develop a philosophy of routine video recording, and if possible, to do this in a way that requires no effort from the surgical team. That is, you put the scope in the body, the video starts. The video recordings need to be stored securely, and each institution needs to determine the permissions for access to those videos. I believe that the first steps should also involve de-identification of the people in the operating room, so that when you take the scope out, for instance, to clean it, that the people in the room should not be identifiable. I think ultimately down the road, perhaps what goes on in the operating room may be very valuable, particularly for research purposes. Once you start to record them, then you should be able, if you have appropriate access, to retrieve the video you want instantly from your computer, from your tablet, from your phone, in high quality and instantly. So if you want to look at a video at Morbidity and Mortality Conference, if you have a patient on the ward who's not doing well when you're making rounds, the ability to pull up that video and review the critical moments is a quality that we should aspire to. We should be able to search by the operation, by events that occur during the operation. I want to see a lap chole with a bile duct injury, for instance, and you should be able to pull up from your library videos that show the type of information that you want. And that's invaluable for teaching purposes. And then once the videos are available and de-identified, then you can either share the entire video or aspects of that video for teaching purposes. So once I believe in the principles of routine video recording, secure and safe storage, access principles, and search principles, the next opportunity is to use some of the technology that is currently available in artificial intelligence, or some people call it computer vision, to process the data that is held within these video files. And the first step that most of these technologies do is what's called annotation. Annotation means machine learning that provides reliable, valid, and automated identification and labeling of the steps, events, and milestones of an operation. Let's go through that. If you do an operation, most operations will have a series of steps that you go through. And the ability of the software to automatically divide an operation into various chapters by annotation makes it very convenient to navigate to the part of the operation that's important to you. So that's the sequence of steps. And the currently available technology is able to do this with a reliability of more than 90% when compared to humans doing that. Other things that computer vision are able to do are to identify events that occur in the course of an operation. An event may be bleeding. It may be that you've made an inadvertent enterotomy and you've spilled bowel contents, or you made a hole in the gallbladder and bile and stones leak out. So you may want to look at a video, go to the point of the video where these events occur, maybe back up a minute or two and see what led to these events, to truly understand why they happened and be able to teach people how to avoid them, and then to follow up and see how they got out of trouble after the problem occurred. A third example of what computer vision is able to do is to automatically identify milestones that occur in the course of an operation. One such milestone that we're quite familiar with is the critical view of safety. And there are multiple elements of the critical view of safety, and the software should be able to, with high reliability, determine whether these elements have been achieved or not. And then you can essentially look at a series of videos and analyze the proportion of cases in which these milestones are achieved, the proportion of cases in which events occurred, etc. And if you think about it, although we've spent a lot of time with the critical view of safety as it relates to lap chole, there are many other operations where there is a moment in the operation where anatomic identification should occur prior to the next step of the operation, which may be irrevocable. For instance, visualization of the ureter when you're doing pelvic surgery. When you're doing a hernia operation, identifying certain landmarks before you cover the tissues with mesh, etc. So the ability for the software to be able to identify this really allows us to understand which of these elements are really critical to safety and quality. The other thing is, once you've done this, then you can search a series of videos by diagnosis, by operation, by events that occur. You could look at a couple of videos side by side and compare things done well and things done poorly. And this now allows us to start to use these principles for education. So certainly during COVID, when we had much of our educational activity done remotely, we were able to work with our residents to pin segments of a video to share and send back and forth to discuss or to evaluate or to coach around. So by pinning a segment of the video is that you can manually put a click on the start and the stop of a certain element of an operation that you might want to focus on. You might want to use this for assessment purposes, etc. And then by email, you could send a link and the person will go to that particular aspect of the operation and be able to review it. You could go through any video by clicking on a step or in the chapter, or as I said, bring up videos side by side. The other thing is that you could then do a quick and dirty video editing process where you say there's 10 elements of this operation. You want to have 1 minute around each element, and then you have a 10-minute automatically edited video, but you've never deleted any content. So any individual person who might want to elaborate on one aspect of the operation that they might want to focus on could quickly review an operation and then go to that step of the operation that they want to visualize. By doing this, you can then come up with a database basically generated by the software to provide a record of surgery that is in the form of a database that is searchable and can be related to outcomes. So mining what we do in the operating room for data is going to be ultimately helpful. So let me just give you an example. So here's a series of videos on my homepage. Sorry if it's a little blurry. I'm typing in Heller. We get a Heller door. Click on the operation comes up. You can see on the right-hand side, the elements, preparation, hiatal dissection, esophageal mobilization, myotomy, wrap creation, etc. And you can see by just clicking on them, you go to that part of the operation that you want. And the quality is quite good. And I have to tell you that the files, just for the purposes of the presentation, have been condensed, so they're not at the highest quality, but they are available. Here's another example of how you can navigate from step to step. So you'll see here's a video of a lap chole. I'm clicking on dissection and skeletonization. Now I'm clicking on critical view of safety, and you'll see that these are the elements that come up. Division of the cystic duct structures, you go right to that, et cetera, et cetera. And this is the kind of the quick and dirty edited video of this lap chole. So there's been a lot of discussion about the Synoptic operative report. That is to manually report an operation in the form of a database with a series of pull-down elements that require you to really put information around all the critical elements. If you, this is just a study that shows that the traditional operative report results in a lot of errors of omission. For instance, in this colorectal review, the location of the tumor, the type of reconstruction, and the distal margin were reported in less than 50%. So you can see that this is a problem, and these are elements that are things that you would like to review. And the other thing is, although you could train people to do synoptic operative reporting, there's a burden to this that they feel will hinder workflow, and they're going to ultimately want to have a narrative operative report as well. So the ability of software to generate a synoptic operative report that provides the minimal information is really something quite exciting. And this was a project that we wanted to work on with respect to lap chole, and we were able to work with theater to develop a synoptic operative report where each step of the operation is actually illustrated, and it's auto-populated by the software. And again, I think this is a very exciting potential area. This is just to show you, this is a speed of 1.5. This is the quick and dirty operative report, operative procedure that is so-called video edited, but it's all done by software, and it just skips from step to step. And you can review an operation very, very quickly. And then you could slow it down. You could go back because nothing has been edited. You're just skipping from one aspect of the operation to the other. So if you enter all your videos, say of your department, then you have a kind of a quick and dirty video library that's searchable, edited. And if you want to see how Dr. So-and-so does a certain operation, it's really quite an easy way to prepare for the operating room. once you start to generate data from an operation, then you have the ability to do analytics, and it could give you times for various phases of the operation. Here you can see the critical view of safety. Well, it was only achieved at 40%, and you could then pull out a case in which it wasn't done completely, go to that case, understand which elements were and were not done, etc. So it's very convenient for reviewing. When we start to look at competency, then by routinely video recording and using artificial intelligence to process these videos, you can focus on specific goals for learning or individuals' challenges. You can evaluate people for individual steps of the operation and track performance over time, because if you just give a global evaluation, it's not that meaningful. Some people can do certain aspects of an operation very well and others not so well. So you could then focus on and track performance, provide comments that are related to specific moments of the operation, communicate between people, and build in a briefing and a program around that. And then, as I said, you could share those videos within your department, and each resident can have their own library. This is just a sample of how this was used for competency-based education by really being goal-directed and putting evaluations in the videos themselves. And then how we can communicate between individuals about specific aspects of an operation. So this could be done synchronously, in person, over Zoom, or it could be done asynchronously. This is just an example from the SAGES video assessment program, where you can see the different elements of LAP-NISN and how a person could be evaluated. And you can see that their performance is not necessarily uniform. So it may be better for the hiatal repair than it is for the mobilization of the esophagus. And you can compare them to their peer group, as I said, or compare them over time. So to put this all together, I think we could really teach surgical skills and decision-making better if we routinely record our videos and use them as a routine part of our training program in a review format. We have to remember that there's a wealth of information from what we do in the operating room that we are not currently capturing. And if we don't capture it and we don't measure it, it's hard to improve it. If we really want this to work, we have to make it easy for people, and it's got to be automatic to record. It's got to be secure. The permissions for access have got to be controlled, and it's got to be available in a useful format. The exciting thing is that there is currently technology that's available, and it's rapidly improving, that allows enormous value to what we would consider to be otherwise dumb or analog videos. And we don't have to discard parts of the video to edit it, and we could navigate them very, very easily. We have to think of surgery as an elite performance field, and learn the lessons that you'd see in football practices or other elite sports in improving performance. We can use these videos for communication, for coaching, for embedding comments, for targeting assessments to specific elements of an operation. And although we are not yet at the point for autonomous AI-generated assessments, I don't think we're ready for that. We have to wait for those to be sufficiently reliable and valid to truly make impactful decisions regarding competency, but we will get there. So thank you very much, and I look forward to the questions later.
Great talk, Dr. Freed. Thanks so much. And next is Dr. Greenberg, talk about surgical coaching and video editing. Thank you.
Great. Can you guys see my slides okay?
Looks great.
Awesome. Okay. So I also have a disclosure that's relevant to the talk. I serve as president of the Academy for Surgical Coaching, a nonprofit organization, and the Academy has received funding from Johnson & Johnson, Intuitive, and Hologic. I personally have not received funding from any of these. So my goal in the next 15 to 20 minutes is to really talk about surgical coaching and what gap surgical coaching can fill for us within surgery. I'm going to give you an introduction to what video-based surgical coaching is, and then talk about how video-based surgical coaching can work. So let's start with the gap. So when we think about technical errors in the OR, I think we like to think that it's people doing things they shouldn't do. And this study from 2007 actually shows that the majority of the time that something goes wrong and there's a technical error in the OR, it's during a routine operation, 84% of the time, with an experienced surgeon operating within their own specialty almost 3/4 of the time. So this suggests that, again, if we wanted to have the biggest impact on improving how patients do in the OR, we would want to have an intervention that targeted all of us, that allowed us all to get better at what we do. And there's an emerging volume of data that is linking those technical skills that we have to how our patients do. Most people are going to be familiar with this landmark study from 2013 by Dr. Birkmeyer and his colleagues in Michigan, where they showed that if you look at the x-axis here, this was surgical skill rating using the OSAT scale of an individual surgeon's performance by their colleagues in a blinded video assessment. And along the y-axis is the risk-adjusted complication rate for the same surgeon. Now, as you can see, the surgeon with the lowest complication rate had the lowest technical skill rating had a complication rate approaching 20%, while the surgeon with the best technical skill rating had a complication rate of less than 5%. And we see a linear relationship between the two. Now, there's been a number of different studies that have repeated this in a variety of different settings. This is just another example, which was from laparoscopic colectomy, where again, they looked at a number of different skills and, it looked at technical skill correlated on the y-axis here with a number of different outcomes, whether it's any complication, unplanned reoperation, mortality, surgical site infection, and see that there is a relationship again between technical skill and how patients do. The most recent data that's coming out is actually, this was published just this past year in 2021, showing that actually long-term cancer outcomes for colon surgery are correlated with the technical skill of the surgeon who performed the operation. So again, what we do not only impacts how our patients do in the short term, but there's emerging evidence to suggest that how we do affects our patients in the long term. And so we're starting to get this empiric data really to support the idea that we need to continue to improve how we do to make sure that our patients get the best outcomes. And I think that the problem is, the issue with where we are in the development of this field is that we've spent an enormous amount of time figuring out how to collect data. So we've gotten very good at collecting data. We've gotten very good at collecting outcomes, but just because we can measure something doesn't necessarily mean that we know how to improve it. And so in order to improve surgical performance, we have to start to move from just performance assessment. And I think Dr. Freed gave us an introduction. I think we're going to hear a little bit more later about how video can really help to grow that capacity for surgical performance assessment. But once we know where we are on some scale in some quantitative way, we have to be able to identify areas and set goals for improvement, have structured ways to reflect on our practice, make intentional adjustments with accountability to what we do, and then see how that impacts our performance again. And it's this circular, continuous cycle of improvement that we all need to strive for. And I would argue that video it can be an incredibly important tool as we look to do this. So with video-based assessment, but also that has to be paired with video-based improvement. And so there are a number of different companies that are starting to develop in this space. And I think that's why we're really starting to see an explosion of the technology that we need to do this in a comprehensive way. There's also a big focus on coming up with more video-based assessments. And I think SAGES is among the best and among the leaders in doing this, but then also trying to think about video-based mentoring and video-based coaching and what do we actually do to support each other and getting better once we know where we are in terms of the assessment. So what is video-based coaching? What do we mean by video-based surgical coaching? And like Dr. Fried, I'm going to draw an analogy to sports. Behind Michael Jordan or Peyton Manning, there's a Tony Dungy or a Phil Jackson, right? And it's almost unheard of to think of professional athlete not having a coach. Yet we often think of coaching as something that's associated with remediation as opposed to optimizing and continuing to improve. So when we think about coaching, these are the two definitions that I like to use. It's about unlocking a person's potential to maximize their own performance. It is helping them to learn rather than teaching them. It's about providing objective and constructive feedback to help someone else recognize what works and what can be improved, and inspiring them to maximize their potential. So when we talk about surgical coaching, I want to make an important distinction because the term coaching is becoming really ubiquitous in our society. We're talking about coaching in the pursuit of improving clinical and operative performance and improving quality, patient safety, and patient outcomes. So things like leadership coaching, executive coaching, wellness coaching, those are all incredibly important applications of coaching, and the principles and the competencies that are used in coaching are the same. But when I use the term surgical coaching, I'm talking about coaching specifically towards improving the way that we take care of patients in the operating room. And coaching is a different, a different paradigm than we're used to. We're used to thinking about and interacting with each other as teachers or as mentors, right? Where we have knowledge, where we have answers, and we have more experience, and we're trying to transmit that to people that are less experienced than us to help them to improve. Coaching really is about supporting someone else and about really focusing on their experience and helping them and guiding them through self-discovery. So slightly different paradigm, slightly different focus, but really needs to be driven by the person being coached. Coaching is very much based on adult learning theory. And I think this is something that we haven't traditionally spent a lot of time thinking about when we've thought about, in particular, continuous professional development and continuing medical education. We know that adults learn best when they are participating in individualized learning, meaning that it's goal-driven, that they're active participants, that it's tailored to their individual experience, and that it's iterative and longitudinal. And again, that it's based on this cyclical process of a longitudinal experience of setting goals, asking questions, reflecting on practice, making some action plan, having accountability, seeing how it impacts practice, and then setting a new goal. And the American Board of Medical Specialties really recognize that the ways that we're approaching continuous board certification are limited. And so they put together this blue paper that came out in 2019. And there were a couple of salient points I just wanted to point out, because I think that coaching really aligns very well with the vision that was put forth by this committee. So the general assessment recommendation that they put forth is that continuing certification must change to incorporate longitudinal and other innovative formative assessment strategies that support learning, identify knowledge and skills gaps, and help diplomats stay current. ABMS boards must offer an alternative to burdensome, highly secure point-in-time examinations of knowledge. They go on to say that continuing certification is unique from initial certification. So board certification, when you first get board certified, is really about making sure that you meet a specific level of competency. But beyond that, continuing certification really needs to switch to be much more formative to support practice advancement. They point out that it really needs to be grounded in adult learning principles, again, highlighting those same ones we talked about on the last slide. So individual and goal directed, frequent spaced learning with timely feedback, repeated for reinforcement, and based on a gap analysis to aid in focus. They also go on to say that for those procedural specialties, we have to start figuring out how to address procedural skills. And they particularly say that and recognize that right now our video-based technologies and assessment capacity are not there, but that they are developing. And as they develop, we need to figure out how to incorporate that into continuous certification. This is a great paper that was studied, that was published by the group from Toronto and the American College of Surgeons, where they looked at a systematic review to identify and define what coaching and surgical education is and how, again, it is a distinct paradigm. So the overarching goal needs to be refining performance of an existing skill set. So coaching in general is not about learning something new. It's about optimizing your performance in something that you know how to do already. That it is needs to be based on a trusting partnership, that it avoids focusing on a summative assessment, that there's two-way communication, that participants are there voluntarily, again, that it's about the self-reflection, self-assessment, and self-improvement that's guided by a coach and follows a plan of goal setting and action planning, and that the coach has received some kind of training in coaching, that it's structured around a coaching model, and that they use open-ended questions. When we think about what surgical performance is and what surgical coaching can target, I do want to point out that it's very important we think holistically about our performance in the OR. So technical skills is the most obvious, but surgical coaching can also help with decision-making and judgment, situational awareness, interpersonal skills such as leadership and teamwork, and then this very important aspect of self-regulation. Now, this last area is something that we did not have in our that was not included in the original models on which our work was based, but that we saw emerge as we started seeing surgeons participate in coaching programs. Surgeons were concerned that they were not recognizing when they were starting to get stressed, when cases weren't going the way they wanted them to, and that they didn't have the right coping strategies for engaging their team and for mitigating their response to the stress to make sure that they were able to continue optimally performing in these other areas. And so that's become an important area of focus. Now, the competencies of coaching, so on the part of a coach, what are we looking for? So a good coach needs to be an active listener. They have to have the critical ability to really listen to the person they're working with in order to develop trust, rapport, and powerful questions. They have to be able to ask open-ended questions to challenge the person they're working with in a non-competitive, non-threatening manner. And they have to be able to give effective feedback that's descriptive, specific, and non-judgmental. So video recording is a really critical component of coaching. Now, it's not necessary. So if you don't have capacity for video recording, that doesn't mean that you can't participate in coaching, but it does make it easier. First of all, it allows you to view your own performance, and there is nothing more eye-opening than watching yourself operate. No matter how smoothly you think a case goes, you'll always be able to identify things you could have done better. It's been shown to be more successful in sustaining behavioral change across a variety of different disciplines. One of the biggest pushbacks we get about surgical coaching is who has the time for this. And the thing about video recording is it allows a time savings of 50 to 80% because you can fast forward, you can rewind, you can hit the salient points without having to stand there in the operating room watching somebody perform an entire case. It removes concurrent responsibilities on the part of the person being coached so that they can really fully concentrate on their own performance. That's the only thing that they should be thinking about during a coaching session. And it mitigates medical, legal, and credentialing complexities as part of peer review on the part of the person in the coach role. So how does video-based surgical coaching work? An individualized surgical coaching process works when a surgeon is matched up with a coach. They participate in an initial introductory session where they learn about each other and they set some goals for their time working together. They then decide what types of videos they're going to review or what types of cases they're going to review, and then have a series of sessions. We usually recommend limiting them to an hour, where they review their cases and think about and again, get feedback, ask questions, discuss the cases, and come up with some areas where they would like to make changes. They then go back to practice, make some intentional adjustments to their practice, re-record a case, and come back and do that again and review with their coach. We are able to offer CMA through any of the programs that I've been involved in partnership with the American College of Surgeons for both the participant as well as the coach. So the first program that we did this with was the Wisconsin Surgical Coaching Program. This was a statewide program through our state surgical society, which is also the state chapter of the ACS. We recruited coaches by asking for peer nominations from across the state and got really a wonderful group of surgeons that we trained as coaches and then members who participated in the program. What we found were that surgeons were able to identify specific coaching goals related to technical, cognitive, and interpersonal skills, that those goals could be effectively targeted during a video-based coaching session, that surgeon coaches could acquire and effectively employ peer coaching principles through our short training, that both coaches and participating surgeons found the coaching program to be highly valuable, and that surgeons reported making sustainable changes to practice as a result of participating in the coaching program, which ultimately is the goal. We came up with a training program as well as finalized what our intervention was, but it wasn't without challenges. So the biggest challenges that we had were related to scheduling and to technology. So this was designed to include 4 longitudinal sessions, but no single participant was able to complete the program. And we couldn't really figure out why that was, other than the fact that people were doing these all in person. Wisconsin is a big rural state, so people were driving 4 hours to have a 1-hour coaching session, and that obviously is not time efficient. And so our solution to this was to try to integrate into existing quality initiatives and surgical societies where we're already taking time out for our busy schedule and already coming together for self-improvement. The second issue was related to technology for video capture and review. And I think Jerry gave us a great overview of kind of where we are and how we're developing in that space. We have been limiting to laparoscopic technical capture, which as a breast surgeon really kind of hurts me inside, but is one way to make sure that we can get these coaching programs off the ground. And obviously in SAGES, this isn't an issue for most of you all. The next thing we did was we partnered with the Michigan Bariatric Surgery Collaborative, and this is an R01 that was funded through NIDDK, where we took the program from Wisconsin and applied it in Michigan. We looked at a number of different outcomes for surgeons performing sleeve gastrectomy, and I'll just call your attention down here to the bottom row where you can see that surgeons who participated in the program had a 15-minute risk-adjusted improvement in their operative times for sleeve gastrectomy following the program. And we saw no difference pre to post for either the coaches or the non-participants. The last study that I want to talk about is just a study that's ongoing with the Abdominal Core Health Quality Collaborative. In case anyone online is interested in enrolling, we are still enrolling surgeons for this. This is a randomized trial where people are being randomized to either surgical coaching, asynchronous video-based feedback, or a waitlist control. Again, this is a federally funded R01 where we're trying to see if surgical coaching or a video-based feedback improve performance, including 30-day procedural complications, as well as 2-year recurrence rates. One of the biggest things that has come up when it comes to video is really this idea of culture change. This is really a huge shift for us in surgery to be thinking about how we can co-learn. How can we work with each other to flip from being experts into being learners, into asking how we can continuously do things better? We do that, but we do that in not very structured ways. And I think coaching is an important thing that can help us to advance our culture change. There was a paper that came out of Toronto that was a survey asking surgeons if they were open to the idea of coaching. And really it suggested that this was counter to our culture. We then did a study as part of that Michigan bariatric study where we asked that question again. And really our findings aligned very much with what they found in Toronto. So prior to starting in the study, surgeons really were concerned that participating in a coaching program might make them appear vulnerable. Despite their concerns about image, surgeons were willing to participate, motivated by poor outcomes or a desire for early career affirmation. So again, finding out where they were on that OSAT scale, where they were with their patient outcomes compared to their peers, or people who were transitioning into practice. Once they had participated, they really found it that it challenged our current social and peer expectations in a really positive way. And they viewed coaching as a way to improve the culture of surgery. So when we think about using video in the operating room, I would like to, again, make the argument that we can use this as an important tool to move from just measuring outcomes and performance to actual performance improvement. As video-based capture and sharing gets better and better, and video-based assessments allow us to measure performance beyond the patient outcomes, we can pair it with opportunities like surgical coaching or asynchronous feedback. And again, I think Jerry gave us some great examples of what asynchronous feedback is, where you just get where you can look at specific clips of videos and get comments inserted. And I think that this is really a key opportunity for professional surgical societies, not only in developing procedure-specific VBAs, but also in providing the infrastructure for coaching programs. And I know that SAGES is a leader in both of these areas. So this is where I'm going to get on my soapbox for a second, because I think this is really, really important. And I think the people on the call should be leading this initiative. Video is going to be in the OR. And if we don't do this, it's going to be imposed on us from outside. I think it's really important that frontline providers are driving the development and implementation of video in terms of capture, in terms of assessment, in terms of improvement, and that we have a really narrow window to do this right. We have to make sure that these programs, as they're developed, and I think, again, Jerry highlighted this very nicely, are constructive and not punitive, that it's based on formative evaluations. When we do summative evaluations, it's not for high stakes, but rather for baseline evaluation, identifying gaps, setting goals, and tracking improvement. And as we do this, we have to continue to do it in an academically rigorous way so that we continue to generate new evidence and figure out how to do it in the best way we can. So I want to thank you for your attention and just leave you again with two opportunities. If you're interested, for those of you that are coming to the end of your fellowship, SAGES has a program. The website, the URL is here, where you can get paired up with a surgical coach as you transition into your first position as an attending. And then, as I mentioned, we're still accruing for the hernia project. I look forward to answering any questions you may have. Thank you.
Great talk, Dr. Greenberg. Thank you so much. We'll proceed on with Dana Telem, talking about innovation presentations for national meetings from University of Michigan. Thanks, Dana, for coming.
Great. Hi, everybody. How are you? So sorry for the light that's in here. I'm going to go ahead and share my screen. I'll just take, as I'm doing this, the liberty of, we've heard a lot of really great things about SAGES tonight. So if there's anybody on this call who's not a member, I'd encourage you to become a member. And for anybody at their institution, make sure that you're encouraging your learners, medical students, and residents to take part in this organization. So I was asked tonight to talk a little bit about video editing for presentation of innovation at national meetings. These are my disclosures, which should not interfere tonight or influence anything this evening, but I did have one disclaimer, and I wanted to put out that I am in fact not an expert in the technical aspects of video editing. I have very crude skills at best. I can put together a video, so I'm not going to spend a lot of time talking about the technicality. What I am going to do, however, is talk about something I think is a little bit more important, because I watch and I evaluate a lot of videos, and it becomes very clear very quickly kind of which ones rise to the top when you're looking through those in a national meeting, and kind of which ones, and I hope to offer some pearls of advice, you know, along the way for everybody here who's interested in submitting videos, not just for national meetings, but even to their own data repositories for their learning. So my goals for today's talk is to really focus on three things. One is quality, which we'll get into momentarily. Two is presentation, or sort of the showpersonship of your talk. And finally is the content. So here's where I'm going to talk a little bit about technical stuff, just because I think it's really important and it's pretty basic. So for those of you who know this already, forgive me. And for those of you who are always embarrassed to ask this, kind of you're welcome along the lines. So when we talk about quality, I think the single most important part of any type of video is sort of the resolution, meaning how well does it show up? And we hear a lot of things called standard definition, high definition, and 4K. And what essentially resolution refers to is the size of the video dimensions when it was captured, namely the height and width, and these are measured in things called pixels. And so when you see, 640 by 480 or 1280 by 720, this really refers to the resolution of the different video. Standard definition is really 640 and 480. And high definition is anything 920 and over. And you want to be careful because this 1280, 720, which many recorders capture in, sometimes is labeled as high definition, but if you're using the strict definition of technology, it's not actually a high definition, but standard definition. And then of course there's 4K. Now there's trade-offs amongst these different resolutions. Obviously the higher the resolution, the better the quality, but also the larger the file and the harder to download and the higher to edit, especially if you don't have sort of powerful servers on which you're going to store all of this content. And so the sweet spot when we think about what type of resolution is beneficial for when you're creating these surgical videos is really this, what's called high definition. This is a challenge though, because a lot of times there's differences in the resolutions between what screen is displaying your video or the device, the video that's capturing the device, and the saved compressed video. And this sometimes is where people get into a lot of trouble. You may be looking at something on a laparoscopic screen that's in high definition or 4D, but by the time it makes it to your USB port, it becomes a compressed file and is really in that standard definition. And so by the time you go to edit it, while it's a smaller file and a little bit easier to deal with, you lose some of that. So you really want to pay attention to the different devices that you're recording on as you move through, especially, and don't just assume because you're capturing it in high definition that that's what it's going to end up being when you go to record it. Couple other pointers, never video a video. I know that sounds like a lot of common sense, but I cannot tell you how many times that I've sat and reviewed videos of a person sitting at their desk using their iPhone to record a video. And we've even affectionately referred to this as sort of the video in video phenomenon. And here just earlier today, I took a video of a video just to kind of prove my point. And what you can see here and appreciate is how pixelated, you know, this video becomes, and that the second you have two interfacing video streams, that it's really just lose all the resolution independent of how high definition that is on your computer screen or other video monitor. You also want to make sure that you're crisply focused. So for laparoscopy, that means a lot of attention to detail of how you're taking your images. And especially for open cases, we don't spend a lot of time about talking about videoing for open cases, but I think these are the most technically challenging to video, just because there's never a really great place for the camera. And there's a few groups that do this really well, but oftentimes what you'll see is somebody wearing a GoPro. And while you get to see a little bit of the operation, sometimes the motion sickness or just the constant movement that happens from the GoPro is challenging. And people talk about things like strapping it to OR light for fixation, but then every time you go to move it, it moves. So if you really want to be set up for this, you really kind of have to be strategic about how you're going to fix your monitor to get the resolution and the depth that you need in the field while not sacrificing kind of the motion artifact that can occur. Audio. Make sure to eliminate your OR audio. You can't imagine how many videos come in and the OR audio isn't deleted, and you hear the music playing in the background, conversations that are sort of happening, the beeps and whistles and all the things from the anesthesia machine, and it can be really distracting. And sometimes that's all the audio that you get, and you always have to kind of put a recording over it. Second, when you do go to record this, really pay attention to your recording environment. I mean, I don't expect everybody to have a studio set up with this fancy mic like you see in the bottom left over here. But if you look at something like this, which looks like a resident workroom, you can imagine that the distractions of people coming in and out, the food, the eating, everything around it leads to a lot of noise, potential distraction, potential things that end up on your video that are unintended, may garble your speech, may not make it as clear as you want to be, and ultimately sacrifice the quality of your video. Next is your recording devices. There's multiple ways to record. And again, I'm not a tech person, so I'm not going to go into the nuances of various headphones and different types of microphones that you can get. But there is a difference between talking into a microphone with sort of a headphone on versus just kind of talking at your computer. So I did two different voice recordings, which I think sound different. You guys can tell me that later. Here's me just kind of talking into actually my iPhone with no recording device or no microphone to capture my voice.
Here is a recording when I'm not using a microphone.
You can hear it's a little bit distilled, a little bit garbled, a little bit less crisp, still intelligible. You can hear what I'm saying. And here, and again, this isn't a great recording device. We're talking about my iPod, so it's just a, a little bit closer, but you can hear, at least to me, a distinct difference.
Here is a recording when I am using a designated microphone.
And it sounds just a little bit more clear, a little bit more crisp. And as you can imagine, the more you invest in sort of time, some of the equipment that you end up purchasing and using, the clearer that your voiceovers will be. That doesn't mean that everybody needs to go out and buy like a $20,000 or $200 microphone. But I think it's important if you're doing a lot of narration and voiceover to have a setup that works, because oftentimes the audio can make or break a video in terms of what's being said. Let's move on to presentation. Make it pretty, get the blood out. I was talking to one of our plastic surgeons and I was telling him that I was giving this talk tonight, and he's like, oh, we always get the GPDs. I'm like, what are those? They're like the get pretty drapes, meaning that every time that they go to, record something that's happening, there's a lot of attention to detail spent of removing the blood from the field, covering things up just with drapes, making sure that everything is clean and crisp and something that you would be proud of to take a look. You can see over here on the left, while this is sort of the same operation as the right, and maybe the right isn't as good because you can't see in, all the blood in the field and everything kind of distracts and just really doesn't make for as clean a picture in terms of what you're trying to point out. So if you wanted to say, point out the drill here, there's too many distractions here that you could not go through. You also have to think about scale. And this happens to me all the times on PowerPoint, and I'm sure this happens to other people. You copy and paste an image and then you blow it up on PowerPoint or on a big screen and it doesn't look right, And what ends up happening is it ends up getting pixelated. So remember we talked about there's a certain amount of pixels that happen in any given image or any given video. And what happens is those pixels don't expand just because you make them bigger. You actually lose pixel. And that's why when you get bigger and you scale things from something small to big, it has that kind of messy or kind of hard type of appearance or kind of blurry type of appearance. So you really want to make sure the scale so that when you're projecting or presenting on a big screen, any of the images, drawings, and diagrams don't end up showing up pretty blurred and not kind of in the way that you want them to show. In terms of presentation, I like to think about video sort of in two kind of ways. One is, what are the non-critical portions of the procedure that end up in your video? And then what are the critical portions of your procedure? And the key about all of these videos is you want to make them short and to the point. Just because you have 10 minutes, you don't need to take 10 minutes. If your video is better in 4 minutes, then you do it in 4 minutes. And the reason for that is oftentimes there'll be some space left on the end of a program. And if there's a really good quick video, we may put that on. And so I think it's a fallacy that people feel that they're forced to like make these really long videos if they can do something that's short and sweet and impactful in that period of time. And what ends up happening is when you're trying to drag something out, you really start dragging out these non-critical portions of the procedure, putting in ports or putting in things which is just distracting from your main from the main point. And it can make the video a little bit less exciting or enthusiastic that you would have. So a couple of different ways to handle that. One, you can splice out unimportant parts that are distracting, meaning that maybe your video isn't longitudinal. Maybe you break out your video in parts like entry and then have a slide and talk about what you're going to do and then show the next portion of it moving forward. Or alternatively, if you know that you're at a non-critical portion, but it's kind of weird to splice out and you have to show it, but it's not that interesting, you can consider speeding it up, with the caveat being that there's many different types of speeds that you can use, and you do run the risk if there's a fine balance in threading the needle between making progress and making somebody a little bit motion sick and dizzy. So you really want to make sure that if you are putting a lot of speed or speeding up your videos, that you're doing that in a way that's reasonable and it's not distracting and not like making someone kind of take back, while watching it. So what about those critical portion of the procedures? Add labels to the videos to aid audience focus. A lot of times now, we might be able in a room when we're looking at your videos to decide what you're doing, but sometimes when we're in big rooms, we don't have pointers anymore or arrows or things where you can kind of show things as you're talking. So take the guesswork out. If you're showing an endoscopy slide, like on the bottom right, instead of having everybody spend 5 seconds looking at the picture, trying to find the mask, add the labels. I love when people add anatomic labels to different areas. So if you're just looking at the abdomen and you're starting and you're showing where the duodenum is, sort of where the difference starts, but make it clear, make it easy, make it really simple for your audience to understand what you're looking at, where you should be focused and where your attention should be. And then when you get to a critical step, freeze frame it, pause, go slow. Don't rush through this. If your whole operation is about, you know, finding a mass or doing something, when you get to that part, if there's something interesting about it, don't rush through it. Freeze it and take your time so that people can really kind of get an idea of what you're doing and moving forward. So I have a little non-medical example, and it's a little cheeky, and I'll rush through it. I was asked in my novice ways to make a video for my daughter to enter her private school, which she's starting. So I guess the video was okay. And I was thinking about making this video, and I was really stressed. And I was like, okay, well, what are all these principles that we've thought of and that we've used? And it's, 7:30 at night. Maybe people will be more interested in seeing a video of my daughter than of, a laparoscopic cholecystectomy. So she'll kill me, by the way, if you guys let her know that I did this. So please, don't, if you ever see her, and you might on a Zoom, please don't ever tell her that I showed this. So basically, I'm not going to watch the whole 3 minutes, but as we kind of go through, you can see we're starting with coming in, and I made this right off my iPhone with the academic portfolio. They asked us as part of this video to come up with 3 different areas. So we did our introduction, and then for each of the areas, we blocked out exactly which skill that she was going to let us know. So now she's letting us know that she wants to do her gem show, which she ends up loving. As we move through, though, for logic, as we transition here, it's showing her and how she can use pennies or how she can use coins to make a different dollar. But kind of at the end, looking at the whole thing of her actually buying the donut wasn't going to really add to the video or create a situation where, that was going to add to what was really asked. But you do want to show people sort of the end value of what ended up happening from her math. And what we did was we just kind of put in a couple still images right here at the end of her, happily getting her donut, putting in her extra tip for the great work that, she did, and then, enjoying the spoils of her victory. So that's kind of what I was thinking about. And I know it's a little cheeky of an example, but it's just kind of applying kind of those same principles and guiding when you're thinking about how to transition and convey information in a clear and concise way that makes sense, that answers the question that's being asked, what's novel, what's innovative, but without the extraneous stuff that detracts and takes away from things and ends up being boring. And finally, make it interesting. It's so interesting to me. I was asked to talk about showcasing your innovation. And I would say that 90% of the videos that we get are common general surgical problems. We get, the same 100 hiatal hernia repairs, 100 robotic, there's only so many operations that we do. And so there's 2 kind of strategies. Sometimes really cool things happen, but you never sometimes know when that really cool thing is going to happen. And I was in the OR the other day, and I was doing this disastrous gallbladder, and it was the first time I'd done a laparoscopic dome down in a while. And I was so mad because I didn't record it because I needed it. And that would have been really helpful for me for teaching and other things. So if you record everything, and some people do this, you'll never have to worry about it, because at the end, you're never going to know what you want and what you don't want. And it can be helpful. You heard Dr. Freed talk about storage of videos and different things. But innovation also, when I think about innovation, doesn't just mean a new procedure or a new technique. It can also be a new way of presenting something, a new way of presenting an educational video, a new framing of a common problem. So what if you send us a hiatal hernia repair, but maybe the content of your video isn't the hiatal hernia repair, but it's 4 hiatal hernia repairs and showing us how you manage a difficult hiatus, right? In 4 different cases. Well, that's way more interesting, right? Here's one, it comes together nice and different closure techniques. Here's one where you do a relaxing incision. Here's one where you bridge with mesh. And then you've taken it out of the purview of, okay, here's your standard hiatal hernia repair with a tough, hiatal closure. And you really made it innovative and around that specific skill set and that specific technique. And it's really also a new framing of sometimes of common problems. So let's say you want to do a video of a difficult gallbladder you did. Maybe you put in a couple different gallbladders with narratives in between, and you teach us kind of what you did and some of the mechanisms in there. So the thing is, it doesn't have to be an interesting case to be interesting. Everything we do is interesting. Sometimes the framing and the way that you put it and how you educate and what you want us to learn is interesting, because a lot of times, we want to save these and we want to put these videos in video libraries for other people. And the more educational that you can make something, the more attractive it is, because that's what people really love to see. Sometimes people want to see 4 or 5 examples of how you do a Nissen, or how you do different types of toupees, even if it's not a super novel procedure. And so, couple parting words. What's a way to ensure 100% that your video is going to be rejected? One is if you disclose identifying patient information. I cannot tell you how many times we'll get a video and someone has forgotten to block out the patient's name on the video or block out like some other identifying information. And that obviously is a no-go for many, many different reasons. And that goes not just for national conferences, but even if you're presenting in your own conferences at home, M&M, always be cognizant when you're showing CTs, when you're showing things, that you're always making sure to block out. Poor video quality, if there's poor resolution, if it's dark, if we don't know what we're looking at, if the anatomy is unclear, if all we see is a sea of blood, if it's not focused, it's hard to accept a video like that. Poor audio quality, where we can't hear what you're saying or why things are novel and interesting. There are very few videos that kind of stand on their own. And so no audio is a way to ensure rejection. A common operation with really no unique contributions, like we kind of talked about. If you're showing us like a standard basic lap chole, even if it's the prettiest one we've ever seen, there's probably 20 videos like that in the archive, and it's not going to spark anybody's attention. Previously presented work. Now you want to look at conference specific rules here. Every year there's a couple videos that we catch that we've seen at other national conferences, and sometimes that's okay if it's international or if it's local, and sometimes it's not. So you want to really make sure that you've known the rules, and if it's something that you've presented before, making sure that it's okay to resubmit it in the conference. And then a final thing that I should add on here too is anything that's dangerous. I think there is a fine line in threading the needle between innovation and danger. And sometimes some of the discussions people have a lot of times is, we want to show this because this is a terrible example of something dangerous not to do, but we also don't want it part of the educational archives. And, and it's kind of a fine line. And that doesn't mean that we don't encourage people sending in complications, because oftentimes when you send in complications or things that went wrong, those are the favorite videos. Like whenever you go to a conference and you have a session on complications, those are attractive. Those are the videos that everybody wants to go and see. But if you're inventing a new procedure and it's like the first time you're doing it and you're doing something that has questionable patient benefit, or a panel of people views it and is like, well, I'm not sure that that's safe, you really, really, really want to pay a lot of attention to detail when you're narrating that video about the safety and the mechanisms to assure safety of that new technology, because otherwise, even if it's really cool and amazing, it may be misperceived and may not be given the same credence. And so my final parting words on why: there's never any video, no matter how beautiful or novel, that can ever be guaranteed to be accepted to anything. And that's okay, because what I think is that you should record videos for you. We've heard a lot from Dr. Greenberg and Dr. Freed that these videos can be used for personal skill improvement. I'm sure if you've recorded yourself as an intern doing a lap chole, and then as a chief, and then as attending, you could watch your progress in the different areas where you move from novice to more proficient and hopefully to expert. It's really a nice way to also document an interesting case or technique. I mean, I'm old enough that I'm going to sort of out myself. When I was training in fellowship, every time I wanted to remember how Dr. Ratner did a case, I would, write down in my notebook how everything was happening and what I had to do. But, a video is worth 1,000 words. And, doing that video, you don't have to do it. And then you have memory. And then also submit confidence to videos so you can learn, and you can go to the conferences and learn from other people. So I want to say thank you for your time and attention.
Dana, we love the picture of your daughter in the videos. Fantastic contribution. Thank you so much. Last but not least, Jaisa Olasky, as a Harvard faculty and Board of Governors member. Thank you so much for coming and talking about the future of video-based assessment.
Thanks for having me. Just give me a second here. Share this. There we go. So I'll be talking today about video-based assessment, working off a lot of what others have said, and especially Dr. Fried's talk at the beginning. So kind of a nice, bookends for the session. I have nothing relevant to disclose. So video-based assessments in surgery, why and how? I'll go into more detail on both of these topics as I go through them, but just to give you a little overview on the why. As I'm sure a lot of you are aware, residency assessments have changed for the better over the years. And instead of it just being, you do this many years of residency, we now have competency-based goals. And so video-based assessment, I think I'll make a case for that having a role in this. Intraoperative teaching can get cut short based on lots of different things, patient factors, OR workflow constraints, peer-to-peer coaching applications, which we've already heard about from Dr. Greenberg. And there's also the idea that video-based assessment and videoing your surgeries in general is educationally efficient. So you can really maximize the benefit from each and every case rather than just learning while you're there. And maybe there's other distractions going on during that case or parts of the operation that are technically very challenging for you. You might learn a lot more from it by videoing it and looking at it again later. And again, there's a need for more objective assessment data. So while we've made progress in that direction, I'm going to make a case for the need for even more. And I will talk at the end a little bit about feasibility and implementation for video-based assessments in general. So looking at some of the barriers to meaningful assessment in medical training, a few of these surprised me, so I just thought I would share them. But as a faculty member thinking about in the operating room, of course, I want to be giving feedback and also being able to make a good assessment. It's great that I have a little app that I can log into at the end of the case and do basically an OSAT, rating of my residents. However, there are still factors that could contribute to me not being able to do this at that moment, whether it's a patient factor or a workflow factor. I think those are probably the biggest ones for me. But looking at this study, you can see there were other things that I hadn't really thought about. I guess mine would fall with the competition between service provision and teaching. But there's also a surprising, I think, number of faculty members on this study who reported either fear of personal repercussion or being labeled as intimidating if they were trying to give constructive feedback. And so they hesitated, and there was some grade inflation that went on where they were overrating in a positive way. And I know that this can also happen when you're being more less precise with your feedback and your assessment, where you might, if you're not really getting down to specific feedback, you might just give a kind of global rating that could be a little higher. And if we remove the live element of it and allow for more time for more specific feedback, we might be able to improve this. Looking at objectivity a little bit further, because I really think that the video-based assessments lend themselves really well to avoiding some issues with bias. First of all, if it's set up correctly, you can avoid single rater bias. So as a trainee, you might participate in one surgery and currently, get feedback from the one attending that was scrubbed with you. But it would be, I think, much more valuable to have multiple raters looking at your videos later. You can also use this to avoid any implicit bias and minimize faculty concerns about their ratings. So again, not to go too far off topic, but there's just a lot of issues that have been demonstrated in various studies when one faculty member is evaluating one resident and they know who they are. And so it could be implicit bias. It could be something that happened during the case that wasn't really, was it about the equipment or something else? And then this was an interesting study. It actually looked at very large numbers, like 2,000 data points. And they saw this, I'm sure subconscious, but this effect where faculty members who were rating, the way the programs were set up, they were rating their trainees first. And then later on in the program, the trainees had an opportunity to rate them. And there was this interesting effect that the faculty who had given out higher ratings at the beginning got better ratings later on. Now, this could be for many reasons. Maybe those faculty are more accurate and they are giving more comprehensive evaluation and they are better faculty members, but they did look at a very large volume of evaluations and thought that this may go, into the data I was mentioning before, where there may be some issue there where faculty members are hesitating to get a reputation like they're a hard grader or evaluator. In addition, when it comes to implicit bias, this was a study of, they sent the same video to over 200 cardiothoracic surgeons across the country, and they had narration and some instructions. And in the instructions, they used words like he and she, even though it was the same video sent to everyone. And so they were looking to see if there was a difference in the evaluations, and you can see here there is. And it was statistically significant when the rater was a male cardiothoracic surgeon with less than 10 years of practice. It was not statistically significant for other groups. Interestingly, they used two different rating scales. They used one that was a global and one of more of a checklist. And on the checklist of individual technical skills, there really wasn't a significant difference, but on the global rating, there was. And I'll come back to that concept a little bit later about global ratings of videos versus checklists. So again, I think that's a good case for objectivity if you do video-based assessment in a way, as was mentioned by someone else earlier, where you really take, I think Dr. Fried mentioned this, where you could take the person out of the video, the audio, as Dr. Telem mentioned, comes out of the video, and making sure that there's really no way for the person doing the assessment to know anything about the people doing the surgery. There are some technology concerns with video-based assessments, so feasibility. We've touched upon this a little bit. There was a study looking at different options and user satisfaction. With robotic and laparoscopic surgery, there's often something built in. It's definitely easier, but how do you get this off the system and where do you put it? That was discussed a little bit earlier. I know I struggle with this myself. Our system is not wired into any kind of cloud. I know in some hospitals it is. And when even I have like a huge jump drive that has tons and tons of space on it, and I even have like an external hard drive, but our system can't compress the videos before it puts them on there. So even with that, it can sometimes not be big enough to hold the files. So there can definitely be issues just depending on where you practice. Also, as Dr. Telem mentioned, open procedures can be much more difficult. So in this study, they looked at a few different options for open surgery: smartphones and tablets, laptops, sports cameras like GoPro, which they called SC, and single lens reflective camera, which is a fancy way of saying a camera for those of us who had digital cameras before our phones did that, and spy camera glasses. So when they looked at that, the GoPro and the regular digital camera scored the highest in terms of the quality overall and the feasibility. So good options to consider if you're trying to work on an open procedure, and then of course, try to figure out how to use your own technology for robotic and laparoscopic. The other issue with feasibility has to do with the person reviewing the video, whether it's you reviewing your own video or the person doing the assessment. So there's different video length options. As was mentioned earlier, you could just capture the critical part of the surgery. You know, if you're submitting it to a conference, you don't want obviously all this extra stuff, port placement and everything. But when we look at full video review, it's even more important when it comes to assessment, because there's studies showing that the percentage of faculty members that completed the assessment when an entire surgical video was submitted was extremely low, like less than 20%. On the other hand, there's also studies that looked at inter-reader reliability. And if you have too short of a video clip, then they were not able to demonstrate inter-reader reliability. So there's some sort of sweet spot there. And one of the studies said, you know, if it's less than 10 minutes, or that one was 10 minutes, and again, it was global ratings, not a checklist, there was no reliability of those evaluations. There's other studies that look at partial videos. So it could either just be one portion or a short segment of each critical task per case. This study looked at 3 different protocols. The first protocol, they took the critical portion of the operation and they condensed it by speeding up 2 to 4 times the normal speed. The second one was edited to include the first 10 seconds of every minute of the critical portion at normal speed. And the third protocol, they did the first 20 seconds of each of those minutes. And when they looked at the reliability of the assessor being able to, you know, have a correlation, they really had equal assessments with all 3 protocols. So this did demonstrate that whether you're looking at it twice as fast, or if you capture a certain amount of each part, that there are feasible ways to cut down and not have the entire video. And this idea of the first 10 seconds of every minute is really, or 20 seconds, is interesting to keep in mind when we think later about assessments that are more like checklists, where you do need to see multiple different portions of the surgery versus just one particular section of it. So looking in a little more detail at the assessment part of this, there's a lot of different protocols out there, whether it's using OSATs or simple, basically the things that we do already at the end of the surgery for a non-video based assessment. Those are really more like global ratings, or do we want to do a procedure specific checklist? But if we do a procedure specific checklist, what goes on the checklist? So if it's going to be procedure specific, this takes a long time to create. You really need to do a task analysis to break down that particular surgery for every different part of the task that the surgery involves. And then we need to take this assessment we come up with. It has to be tested for inter-rater reliability. It also needs to be able to discriminate accurately between a novice and an expert. So we can't just put together a checklist and then start using it without studying it first. Fortunately, there are some assessments that have been looked at. The American Board of Surgery already has these. These were not specific to video-based. These are just checklist-based, specific to each procedure, operative performance assessments. But this is a good starting place. And it, again, is a checklist. And then SAGES has the master's program, which the curriculum is not completely out there yet. So this is just the current SAGES website shows, but what was published in 2020 was one of the video-based assessment rubrics that's been created already. This one is for a lapnicin. And so this was exactly what I was saying before. You do a task analysis to really take that one surgery and divide it up into what you think the most important tasks are. This involves Delphi surveys of experts. This involves, large surveys of membership and subject matter experts. And so you can see it's divided into these different topics, and then it's a checklist based scale. And when they've done studies looking at this with checklists, you can even take non-surgeons. This hasn't been studied on this exact assessment, but in general, it's been done for video-based assessment in different publications, where you can take non-surgeons and non-experts. And if you give them a global rating or you give them a checklist to look at a video of a surgery, with the global rating, there will be no correlation for like crowdsourcing the evaluation. But if you look at the checklist, you can actually have non-experts follow the checklist, and you can have good inter-rating reliability, and it will correlate with the score on the checklist that an expert surgeon would have given. So there's some really good data about that, which would help us even more, because go back to what I talked about at the beginning, if you imagine a scenario where the video that you've recorded de-identified from who the participants are and the patient goes to two other faculty members or non-faculty members, and they're looking at it, it's really good to know that if you have a procedure-specific checklist, you can likely get good data from that. So again, just implementation. First, whether you're trying to do this for yourself as part of a study, if you're a trainee, or if you're a faculty member who wants to work this into your resident evaluation process at this point, first, you really need to decide on a rating tool. I would heavily encourage you to use a checklist-based one. If you couldn't tell from the rest of the talk, I think we already do enough with global assessments, and global assessments are just so vague and really have a lot of room for bias. So a checklist-based tool is going to allow you to have more people more accurately rate the video, and also likely be more objective. But you also need to then decide who is going to edit the videos and with which protocol. And what is your goal? So is your goal to use this during the training process as an educational or formative feedback method, which would be an excellent idea? And, as a resident, is how you would use it yourself? Are you going to spend time giving specific feedback to those residents? Or is this a high stakes summative type of process where at the end of the rotation or before you finish a certain year of residency, or the boards or those kinds of things, these are submitted for a high stakes grade, which is kind of part of the model for the surgery, the SAGES mastery program, as opposed to like a surgical coaching program that was discussed earlier, where it's really more educational and informative. So that's all I have on that topic, and I look forward to answering any more questions about that. Oh, I did want to say one more thing, actually. Just to mention that I showed the one for Lapnissen there because that's been published. But if you do go to the SAGES Mastery website that I showed, you can see all the different types of topics, and just know that there's video-based assessments in the works for basically almost all those topics. So if you are interested in implementing this in your program in the future, SAGES will have resources along with the American Board of Surgery to help you use an assessment checklist that is objective and has been tested. Thank you.
Very thorough and complete talk, Jaisa. Thanks so much. I'd like to open the group discussion with some questions from the chat. I know there's a lot of discussion about the controversy of institutional practices and whether these videos can be used in the court of law for malpractice and for other things that actually make it disadvantageous to record these. Do y'all have any group opinions on that?
I will just weigh in and say that they can be used in a court of law. I don't know of any legal protection currently, but I also think that that shouldn't really stop us from using it. I think Dr. Greenberg had put some great things in the chat about potentially trying to find ways for legal protection, but we really are striving to have our operative reports that we dictate accurately reflect what we've done. That also can be used in a court of law. And so if something in your video is that different from what you dictated, I think there's maybe a different issue going on at that point.
And I think that's something that is pretty controversial, and I've been involved in a couple of different panels that have discussed this issue. I've talked to lawyers in 3 different states now about this. And in general, most lawyers say that even if it is admissible into court, it's most likely to show that you provided standard of care and actually act in your defense than it is to be used against you. And if there was an egregious error or some standard of care was not met, quite honestly, they'd rather know and settle than drag everyone through a long, complicated case. And so there's a lot of people that sort of think that either way, it's going to be advantageous. The lawyers I've spoken to have drawn analogies to when they first started using the strips in labor and delivery, and there was a lot of concern about how those were going to be used in legal cases, and in general they most likely were used in the benefit of the defense. But I think there's a lot of work going on around, again, how does this fit within peer review? There's a lot of work about patient safety organizations and what kind of protections do we get from that. A lot of the programs that I described have been done as part of NIH studies. And so there's protections that are given as part of being in a federally funded grant. So there's lots of different ways that you can kind of look into where your protections might live.
All right, I know there's some feedback from the chat box. Does anybody have any preferred video editing software they like to use that's intuitive and easy for the residents to learn?
I'd have to look at like my desktop to find the app, because I actually think a lot of them are pretty straightforward to use. A lot of it is kind of, it shows you how to trim clips, you can splice things. I think when it comes to adding audio, some of them are a little more complicated, at least that's what I found, but I don't actually know the name of what software I've used most recently, because usually it's like a free download and they're mostly pretty simple to use.
Great. And Jaisa, I think this question's for you. It's a good question, is whether video-based assessment should replace outdated Acgme case logs for assuring competency-based category minimums for board of surgery for qualification for the exams. What do you think?
Oh, that's a really interesting question. Well, and I kind of mixed feelings about it. I mean, I think it sounds like a great goal to have, but I think the logistics of making sure that everyone can accomplish that, we're still a lot of years away from. And I think the case logs in general are good because it's not, a lot of surgery and learning is repetition as well. And it's not all about doing the surgery every time. It's also about seeing it and being there for multiple different versions of the same surgery. So not every Nissen is the same. In fact, I would say no two Nissens are the same. So it probably makes sense to have a little bit of both at some point down the road. But for now, I think maybe the residency programs could get more involved with video-based assessment on their end rather than it being a high stakes situation.
Could you talk about your Board of Governors' role in helping video-based assessment really help the Fellowship Council for laparoscopic and minimally invasive fellowships reach that standard? I know that's one of the goals of SAGES now. Does that question make sense, Jaisa?
No, were you asking? I thought you were saying
Well,
that there. I don't actually know much about how. Maybe someone else knows more
Council's
about.
interested in using
Yeah.
that for accrediting people, starting with the lap Nissen. I wondered if you had any feedback on that or any knowledge of that, or any comments from the group about use of that in the accreditation process for fellowship training.
I think the competency is more than case volume. I certainly think that we need to do something in addition to case logs. And certainly people learn at different rates. Their participation in operations can vary. There can be a lot of variability of the attendings that they work with. I mean, there are many, many factors. So I think we do need to incorporate some form of competency-based assessment. Video is one aspect of that, but I think there are other things like the Fellowship Council has been also working with the EPAs. EPAs actually are very helpful because it gives you some insight when the fellow does their own evaluation of their ability to autonomously do a surgical act. So I think that there's more than video-based assessment, but video-based assessment should play an important role in determining competence.
Great answer. Thanks so much. I think there's another question in the chat I'd like to bring up that was very productive. And the question is how we can steer machine learning and computer vision targets toward quality improvement and skill acquisition refinement, rather than just use them for productivity and accreditation. Any thoughts on that question?
Well, I have some thoughts. I think that we're relatively early in the evolution of this technology, and it's important that we, as surgeons and thought leaders, get involved in directing the technology to meet our needs, and to also do the work that's required to study the information that it provides in terms of the validity of the information, et cetera. Certainly there will be people that are going to use it for whatever purposes they feel appropriate to, but that they're already doing that, right? I mean, you could chart different surgeons' times to do procedures, blood they use. I mean, you could, that's happening. But I think that the key is that we need to get involved. The people that do the technology, they're software engineers and people like that. We have to define our unmet needs and ensure that the technology is directed in the proper way.
And just as a group question, I know that the OR black box technology is becoming very popular right now. Do y'all find any surgeons that are actually reticent or hesitant to have their videos taken or recorded for peer feedback? I think that's become a big issue in the future when they institute a black box, whether people actually do want to have those videos recorded and analyzed by administration and other people.
I could address that. I think that the black box provides a lot of information in addition to the video, and but it takes away all the privacy of the operating room. So, and this is my own personal opinion, I think right now the black box technology is very interesting for research purposes, but for a large deployment, you have to get, for us, we would have to get the nursing union to agree with it. We'd have to get anesthesia. I mean, there are a lot of players other than the surgeon that we would have to get involved because there is really no privacy in that technology. I think if it's used in a way that that all the users really are interested in the information and they're using it for research purposes, I think that provides powerful data. But I think if we want to get this adopted, it would be more logical to do it in a stepwise fashion.
Great
Yeah,
answer. Thank you.
I think it depends a lot on the culture of the organizations and sort of where organizations are in terms of the use of video. So one organization where I tried to do this, they were totally fine with video recording for later review, but they absolutely did not want it viewed in real time. And then the next institution I went to, they were fine with looking at it in real time, but they had concerns about recording it for later use. And so I think it depends on sort of how it's rolled out. I think that the point about thinking about the team holistically and who's going to be recorded is also super important. When we did this in Boston, going and getting the nursing union as the first people to back us was one of the most important things that we could have done. I would say that in my experience coming at it from a research perspective, where we've usually had an opt-out approach, it is actually a very small minority of people that have opted out of participating globally. And some of those people, as others had got comfortable with it, have come back and agreed to participate. So I think a lot of it is sort of this fear of Big Brother. And as we get people just more comfortable with the idea of it being used, and again, this is why it has to be rolled out in a constructive and not punitive way. I think that's the most critical thing.
Great feedback. Thanks. There's several comments that are interested in the surgical coaching slides, the Academy of Surgical Coaching. Do you want to talk a little bit about how you want to expand surgical coaching through SAGES and other initiatives?
Sure. So if people are interested in learning more about surgical coaching, I'd encourage you to look at our website, Academy for Surgical Coaching. A lot of the information that I presented is either on there in various forms or will be on there in various forms in the upcoming couple of months. You know, the idea of surgical coaching, I think, is one approach. I don't know, it's not sort of the be all end all, but it is one way that you can use video to improve performance as opposed to measure performance. And I think that those are two incredibly important sides of a coin that we really can't do one without the other. There are a number of different organizations and societies that are really interested in this concept. And I'm really hoping that we can put more pressure on our societies to offer more of these types of activities at our meetings where we're coming together. So, you know, again, when I think about it, I'd love to, when I go to a national meeting, be able to go to one room and sit and watch a PowerPoint, be able to go to another room and there be a bunch of trained surgical coaches with computers, and I can pop in my you know, my stick and get some feedback on what I've been doing. It just seems like we have to be thoughtful about how to integrate this into what we're doing already.
Great, thank you. I saw a very interesting comment for the chairs. It's an interest in a question whether the operating room video would add value to hiring decisions for surgeons coming straight out of fellowship.
So this is such an interesting question, and I think that this is such a gap, and I don't even think about it for surgeons coming out, but every time I go to hire someone, and we've hired 6 or 7 people this year, you hire someone sort of sight unseen, and imagine that sort of in the context of hiring somebody to play in an orchestra without having ever heard them play, but because I called Caprice or Brian and they told me that they're good, you know, kind of giving that thumbs up. And sort of, you know, what can we do to assure proficiency, not just at the novice level, but at every level when we hire someone? And how do we credential people, and how do we continue credentialing? How do we, you know, if there's concerns about somebody's operative technique or for cognitive decline, especially as we transition into later years of practice. So I think that this is a really untapped and amazing field. And I see Caprice smiling because I'm sure she has like a lot of thoughts into this as well. But I think that this is a really interesting question and space to move into.
And so I guess I would agree, like, I think it's the holy grail and where we need to get to. I have significant concerns about using video for privileging or hiring or any of this high stakes stuff early on. Again, just because I think if people get scared off and we start to have resistance within the community around it, I think that could undo a lot of the good that we could do. Again, I would love to hear other people's thoughts on this because there's a whole bunch of different ways that you could approach it, right? But I think that we're going to be better off trying to use it sort of constructively for improvement, and then ultimately getting to the point where we are using it for hiring decisions, privileging, those types of things. But I worry if we start off with that too early, it's just going to be too much for the culture change. And I think one other piece of it comes back to, I think what Jaisa talked about some too, which is until we figure out the assessments and we really trust them and know that they're objective, I think it's also very challenging to not have a lot of clarity around the reliability, around the biases, around some of the challenges that we have with those assessments. Don't leave me hanging, guys. Somebody give me your thoughts.
I agree with that. I think you said it very well.
And from a training perspective, it's absolutely correct. There's no good way in when we graduate people, we can accurately describe operative autonomy and what progress people make in these cases. That's where we have a lot of people that actually go out and have real problems failing out in practice because they haven't really had the ability to struggle in the operating room. And I think that's what you can really detect through videos, is where they're struggling through the case and how they can make accurate progression. So that's great feedback from chairs and employers like Dr. Telem. Thank you.
And I think from the standpoint of the assessments, the nice thing about these procedure-specific ones that are being developed, if you look at the published paper for Lapnissen and from what I know of the one that's in the works for Lap Coley, it's really based on that task analysis, and it gets around the idea of like, oh, which co-applier do you use, and things where you might now be in the OR with someone else, and sometimes there can be a perception because of a difference in practice that's not really substantial. There could be a perception, well, they don't do it the way I do it, and that kind of thing. And this gets around that, because if you look at these assessments, these are core steps that everyone agrees on. These are safe steps. And they have what the bad things are too. You know, did they make this bleed? Was this particular danger thing done? And they ignore stuff that's not substantial or really important stuff that might just be a difference of technique or equipment. So I think that's one of the strengths also, where otherwise, you know, I had trained on the West Coast for residency, and then I came back to the East Coast for fellowship and a job. And actually there was a huge difference in the way that the, you know, open small bowel anastomosis was done differently. By like, it ends up the same, but the step-by-step technique was different in one place versus the other. And I was the only West Coast person, you know, and I said, well, everyone I've ever seen do it this way. So there were like all these, but the steps of it were the same. It was just a slight difference in like, oh, what suture do you use? Or do you staple this? Or do you sew it? That type of thing. So again, I think with these objective step-by-step checklists, you're avoiding all of that kind of stuff and just getting at what's the core thing. Did your anastomosis, was it patent? You know, is it bleeding? That kind of stuff.
And that's where I think the work that SAGES is doing is so important. You know, I know that it's taken years to get just one of these done for Lapnissen, but I think that, you know, it's being done in such an objective, such a rigorous way that people are going to be able to, as a community, stand behind it and say, you know, this is what's important. And then I think the question is, you know, at what point do we use them? Right? Because it's going to be so labor intensive to use a 50-point scale to do an assessment. And how do we then pair that up with the global assessments? I think it's going to be really key. But I think it's super exciting, and I think we're going to get there. I just think we're so early in the process.
I think we've answered all the core questions from the chat. Any other comments from the group? I'd like to encourage all the attendees tonight to become SAGES members, and like to thank a very creative, very futuristic, and really thought-provoking panel tonight. I think it's been a great webinar and really forward-thinking. Thanks so much for Dr. Freed, Dr. Greenberg, Dr. Olasky, and Dr. Telem for a great video panel. I think let's wrap it up. Thanks again.
Thank you.
Have a good night.
Thank you.